Hello, everyone, and thank you for joining us for another one of our Meet the Specialist sessions. Today, we have the very, very lovely Dr. Kalesh Seevnarain. He is an occupational physician and he works in Queensland. We also, pardon me, we've had a long-standing arrangement with this business in Queensland. This doctor writes an excellent report and has a really, really great reputation for not only his patients, but for people who see him for medico-legals. So please know that you can access this wonderful doctor through the Mag Connect portal for some excellent reports. Now, the purpose of these sessions is just to introduce our specialist to our clients and so that you can see what they're really like in the flesh. So without further ado, I'll hand over to you, Dr. Kalesh, to just have a chat about you and your areas of expertise. Thank you.
Hi, thanks so much, Michelle. Hi, everybody. My name is Dr. Kalesh Seevnarain, and I'm an occupational and environmental medicine specialist. A little bit about me. I initially did my undergraduate and postgraduate training in South Africa. I qualified as a specialist in South Africa, and then I spent 5 years in Papua New Guinea, where I was the country medical director for a large multinational company. Oversaw a number of projects in Papua New Guinea, largely in the oil and gas industry. I did a construction project for ExxonMobil, Total, Horizon, Talisman, exploratory projects, very, very remote type medicine. Infectious diseases was quite prominent in Papua New Guinea. And then I decided to try and come across to Australia. Spent a year and a half down in Melbourne. Then a year and a half in Sydney, and finally ended up here in Brisbane. I've been in Brisbane now for about 8 years, and I will swear it is the best kept secret in Australia. I'm quite happy to have settled down here. But currently I run the practice here at Forcing Risk, and we have a number of clients. So apart from me doing medical legal work, I'm actually a practicing occupational physician. So I actually see patients and manage injuries, stuff like that, through the course of my day as well. I play a significant role. I have a significant interest in teaching and education. I was in charge of all of the trainees here in Queensland, but now I'm currently the chair of the training committee across Australasia for occupational and environmental medicine physicians. I have just finished up drafting the syllabus that we expect to change for specialists in occupational and environmental medicine across the two countries. So hopefully, I'm trying to give back to those specialists now coming through the process and making sure that when you refer to an occupational physician, there's a certain level of quality and assurance and that you'd get from them. Areas of interest, in terms of where I come from, South Africa, pneumoconiosis is a big thing for us there. So I like silicosis. I've written a journal article, a small journal article, a very small journal article about it up here in terms of tunnel workers that we see. I'm also the chief medical officer for railway projects and stuff up here. So I do that. Then I like education. So I think I spend most of my time trying to help other or mentor other occupational physician trainees and stuff like that. So those are kind of my areas of interest and what I do. Aside from being up here, I have 3 kids. The eldest is 6, and the youngest, we've got twins that are 4. So I'm constantly in a state of flux, particularly in the mornings when I have to drop them off at daycare. But otherwise, I think that's about me.
Wonderful. And do you ever drop them off at daycare and then keep on driving to work and realize that you've still got the Wiggles on and you're singing along to the Wiggles?
Well, I think we've played Baby Shark.
Yeah.
So many times. Right now, I just leave it on. Yeah.
Yes, it gets a bit like that. Look, I will open up to the attendees who may have questions of you, but I have two questions from people who are unable to attend today, although they registered. And one was actually of real interest to me because I also lived in Papua New Guinea and caught a infectious disease. I got malaria. And I was interested to hear, obviously, Queensland has areas that are dengue fever zones. And with the rise in natural disasters, events like heavy rains, flooding, cyclones, are you seeing a trend of dengue fever moving outside the traditional tropical areas where we've normally seen it?
Yeah. So like most things, the more you learn about it, the less you seem to know. So I think as an occupational physician, there's two ways to approach that or approach dengue. Number one is actually from an environmental point of view, because with climate change and the change in terrain or the change in rainfall and patterns and stuff like that, you actually see a change in the way diseases are distributed. And malaria and dengue are probably the most prevalent in that sort. The minute you get pools of water, mosquitoes, you do get an increase in those type of vector-borne diseases. So definitely, yes, there has been or there will be a change in the way those diseases are distributed. The next part is, the more interesting part is that if memory serves me correctly, the dengue vector or the mosquito would only move in certain way. So it lived in little puddles of water, which would collect in like tires and little bowls and stuff like that. And the mosquito wouldn't fly more than 400 meters from that location. So what happens is that sometimes you actually need to just look at the environment to determine if it's really going to affect you or not. And particularly in the work environment, if you did simple things like vector control and emptying out these bowls and removing tires and stuff like that, you probably just would be able to manage dengue, with those simple interventions.
Yeah.
Yeah.
Do you think we'll ever get malaria here?
I don't think so. I think you need the Anopheles mosquito for that. And, we probably don't have that as yet. So
it makes me happy. The next question is in relation to occupational exposure relative to dust diseases. And this has come from a lawyer who said that they are seeing a slight increase in people who are perhaps in their 50s and 60s who are just now getting symptoms, respiratory symptoms in particular, but in relation to jobs that they did 30 years ago, like panel beater or spray painter and things like that. Is that something that you're seeing from an occupational medicine point of view?
Well, we're seeing the re-emergence of silicosis, and obviously it's been in the newspapers, and there were television series and stuff like that, or programs where you had the stone top bench workers. They were affected by silicosis, but we're starting to see, because what's happened is because of the publicity that those things have received, doctors now have a greater awareness of those conditions. So the system is set up to diagnose more of those types of conditions. So you do start seeing a lot of those types of respiratory complaints come through. Now, whether that translates into a disease which is work-related, which is another story. So not only can a disease be caused by work, but it can be also aggravated or precipitated by work. So you've got to go through the whole, like a kind of a causation model, and you've got to understand, is something that really happened 30 years ago still relevant to that? What I teach the trainees, or what I talk to the trainees about is, when you look at those types of cases, it's always important to have a set of principles by which you can try and either establish causation or reject the theory of causation. And the most scientific one that we use is called the Bradford-Hill's criteria for causation. I don't know if you've come across it.
Yes, yeah, it's a really great tool.
Yeah, exactly. And if you can systematically go through them and prove that a disease is causative, then at least you're making the right decisions.
Yeah, I think PFAS with firefighters would probably fall under that category as well.
Yeah, but again, you have to go through the Bradford Hills criteria, and from what I can understand is that yes, there's definitely an exposure. Yes, there may be some health effect, but they haven't really tied the two together just yet.
Right. Okay. And I've got one more question for you. And that is, I had a discussion with a lawyer only the beginning of this week, actually, and we were talking about who might be best to assess a client with a particular series of injuries. And the injuries were work-related. That had already been accepted by the employer. And the person had to have a shoulder reconstruction, some sort of spinal surgery, I think. But they actually had a knee replacement as well. And they were saying, oh, we want an orthopedic surgeon to look at this. And I was saying to them, I think an occupational physician might be better if you're looking down the track of long-term capacity of this person to participate in the workforce, to return to the workforce, and in terms of their future prognosis based on those injuries. I mean, an orthopod can certainly talk about whether the surgery was warranted, whether the surgery was performed correctly, and whether it's currently stable. But what would you say to that?
I would say it would depend on the question that you were trying to answer. I think that each specialty has its advantages and disadvantages. The orthopedic surgeon is very knowledgeable in the type of injury, the surgery that's required, some of the recovery periods and the complications that can go wrong with the surgery. But the advantages of the occupational physician is the occupational physician actually is best placed to talk about whether an injury is work-related or not. The occupational physician is best placed to talk about a return to work. So while the orthopedic surgeon will say, you can lift 20 kgs, whatever, does that mean that Michelle can go back to her job? That doesn't really answer. Yes, it might give you sometimes a good indication of whether that can be achieved or not, but really doesn't directly answer the question of work capacity. If you need more management of an injury, more rehabilitation or advice on rehabilitation, or a fitness for duty assessment, the occupational physician is better placed for those types of things. I remember talking to some of my colleagues down in, and they were psychiatrists. And we're talking about, the suitability of these types of different things or different cases and stuff. And I remember telling one of them was, but this is what I do every day. Assessing fitness for duty, assessing whole person impairment, giving recommendations about rehabilitation and stuff. That is my specialization. So the fact that I'm doing it for medical legal reports is by the way. I would still be doing it in my normal practice for a different patient if if the situation or the client came in. So I think that the fact that sometimes you might think, oh, the expert, or I need this certain type of orthopedic surgeon because they're an upper limb experience, and this is like a little finger on this side, and it just depends what the answer you're looking for is, and who's the best placed person to give you a good answer about that.
Lovely, thank you. Is there anyone here who has a question that you would like to ask of Dr. Seevnarain? You can just unmute yourself and speak your question, or you can type it into the chat. Oh, in the chat. Do you travel to Tasmania for assessments? And if not, do you want to take assessments via video link?
Yeah, so I actually did travel to Tasmania.
Pneumococcus conditions.
Oh,
pneumoconiosis.
Okay, sorry, I didn't hear that second part. I did actually travel to Tasmania for a couple of years when I first started working, and I love Hobart. I used to actually land in Launceston, see people the next day in Launceston, then travel down to Hobart, and then see people in Hobart, and then come back home. The trouble is we had our twins, and travel became a little bit too much. So I don't travel down there anymore. I'm more than happy to see people via telemedicine. But I think that when you start leaning towards telemedicine, number one, in order to make it a very concrete type of medical assessment, sometimes you may need assistance in examinations on the other side. And with pneumoconiosis, it can be a little bit difficult because it's a respiratory system, so you can't use a physiotherapist or somebody like that. But it's quite easy to overcome that by using imaging like a CT scan or an X-ray, or even doing lung function tests and stuff like that. Because you're trying to answer questions about functionality and capacity, and those things come from those types of or those other investigations. Whereas if I just examine somebody, I might hear a few crackles and that kind of thing. So I do think that sometimes you would be able to do an assessment by pneumoconiosis, but with all telemedicine, I always give a caveat: I can try my best, but sometimes if it just works out that the condition is too complex or something happens, then obviously I'll put that down as a limitation in the report.
Thank you for that. Hilary, I'll see if we do have another occupational physician who is travelling to Tasmania for you. If you want to leave your email for me, I can definitely do that. And we will, of course, let you know when Dr. Kalesh starts travelling again, if he does. But he's being a wonderful dad at the moment, which is really admirable. Does anyone else have a question that they would like to ask? No? Well, that's great. I think we've covered quite a few things, and I think you've had a chance to see the breadth of this wonderful doctor's expertise, but also the really great thought that he puts into his responses, and of course to his dealings with clients as well. So thank you all for making time to be with us today, and thank you so very much, Dr. Kalesh Seevnarain. Have a great rest of the day.
No worries. Thanks so much. Bye-bye.
Bye.